Good evening, and thank you very much to Dr. Cosmides once again for the opportunity to be here with you today for our annual meeting. And today the subject that I'm going to present is maybe somehow familiar to you because it is inspired by a presentation that Dr. Tsarouki here provided to us 3 years ago in this same room, the Saturday like today, for our annual pediatric oncology meeting. And she was presenting all the aspects and the problems that are connected to the administration of gadolinium in magnetic resonance. So she was raising the question, the Shakespearean question, to God or not to God. So today, I wanted to go back a little bit to some aspects of this presentation just to see if in these 3 years that have passed, we have or we can at least translate somehow at some degree all of this information and knowledge that she provided to something that we can use in our clinical practice, clinical routine. So first of all, as we know, in CNS disease, contrast enhancement MRI is useful for the visualization of small lesions, for the depiction of an impaired blood-brain barrier, for the revelation of vessel structures, for the detection of primary and secondary CNS tumor. And at this regard, the MRI with contrast enhancement helps in providing information on the location, on the grade of the lesions, on treatment planning, and on the monitoring of responses to therapy. The administration of gadolinium is associated with a very low rate of adverse reactions. We have hypersensitivity reactions in only maximum 2.4% of the exams, allergic reactions even lower, 0.7% of the exams. Life-threatening anaphylactic reaction is extremely rare, 0.01%. And we know that the strongest adverse reaction predictor factor is a previous history of an adverse reaction in the previous gadolinium administrations. So if we have such a low rate of adverse reaction, why should question the utility of the gadolinium? So why not to God? And indeed, up to 2006, the gadolinium-based contrast agents were considered safe. But in 2006, a first report about the link between the nephrogenic systemic fibrosis and the administration of gadolinium appeared and reported of this association in patients with renal dysfunction. This is a potential life-threatening condition that is characterized by fibrosis of the skin and potentially systemic involvement of the joints, the heart, liver, muscles, and lungs. So, but this condition seems to occur only when the linear gadolinium is used. But there is also another evidence that came out in the last years, that is the evidence of the gadolinium accumulation in human tissues. There is a tendency of gadolinium to accumulate within various tissues of the human body, mainly in brain and in bones. As regards the brain, there are radiological evidences of linear gadolinium deposit in the globus pallidus and in the dentate nucleus. And there are autoptic studies showing the presence of gadolinium, not only the linear but also the macrocyclic gadolinium, in brain tissues. And if we look at the bones, it seems that the concentration that the gadolinium can achieve in this tissue could be even 23 times higher than what has been observed in the brain. The deposition of gadolinium is dose and age dependent, and it is not related to kidney function. At present time, the effect of the long-term deposition, especially in young children, are unknown. The deposition of gadolinium in globus pallidus and dentate nucleus might potentially increase the risk for future movement disorders and cognitive problems, but we don't know it yet. For the moment, the linear gadolinium have been suspended from the European market. So with this background, gadolinium-based contrast agents should be applied with some caution, and maybe we should be more it should be applied in a more selective way. And that's why recently the neuroradiologist community and the neuro-oncologist is questioning if brain tumor imaging without gadolinium-based contrast agent is something feasible or just a fantasy. Well, the neuroradiologists are exploring this issue and see if dose reduction in the gadolinium or the omission of the gadolinium could be feasible, and if doing this, we can still be able to, for example, differentiate the nature and the grading of the lesion, low grade versus high grade, true progression versus pseudo progression. If doing that, we can still obtain an optimal therapy planning regarding the surgery or the planning for the radiotherapy, for example. And if we are still effective in the way that we survey, we do the follow-up of our patients. And there is some optimism because in our days, the recent advances in the field of machine learning, artificial intelligence, together with the advanced technique of MRI, let us think that maybe in a future, in a close future, it will be possible to omit the gadolinium and still keep the same efficacy in the magnetic resonance can provide. So for today, we focus on the pediatric studies regarding these issues. And most of the papers regards children with low-grade gliomas. And it's easy to understand why, because this is a disease that has a very good prognosis, but that it represents a sort of a chronic disease where the children have to undergo several MRI during at least the first 10 years from the diagnosis. And here in these slides you can see that according to the guidelines and the recommendation from the from COGS, also our American colleagues, the guidelines in the COP protocol, or the CCLG recommendation, these children, they receive a minimum of 12, 17 MRIs in the first 10 years that follow the diagnosis. So they are a particularly vulnerable population for the, especially if we think to the potential long-term effect of the accumulation of gadolinium in their tissues. Now, if we look at the guidelines by the RAPNO working group, the Response Assessment in Pediatric Neuro-Oncology, we see that the guidelines, they recommend a core sequences for the brain MRI. Brain MRIs have to include T1 sequences, T2, T2 flare, and they also recommend the T1 plus contrast, and then also the diffusion-weighted imaging. But the same authors acknowledge that although contrast enhancement T1 imaging is a mainstay for the assessment of brain tumors in general, the use of contrast agents in pediatric low-grade glioma is controversial. And indeed, the literature does not have a substantial amount of data discussing the specific use of post-contrast imaging for the response assessment in these children. However, clinical experience suggests that the contrast sequences are useful to assess the response because many of these tumors present a different degree of enhancement. So as you see, this is not a strong evidence based on the literature, but it is a weak, moderate, I would say, evidence based on the expertise, on the clinical experience. Furthermore, the RAPNO working group, they defined the criteria to assess the response to the treatment. And as you can see, they recommend to measure the response on the basis of the size of the target lesion on T2 and on T2 flare. And on top, they say that both an increase or decrease in enhancement do not contribute overall. So when we define if a tumor responds or not to the treatment, we measure the response on the T2 sequence and not on the enhancement areas. So if we look at the literature, there are several papers regarding the use of the gadolinium in the surveillance of children with optic pathway glioma, questioning if the use of gadolinium is really necessary. Here in this paper, this is a retrospective study on 38 children with optic pathway gliomas, NF1 and non-NF1. They observed 18 cases, 18 children, for whom there was a change in the clinical management on the base of the radiological exams with or without clinical elements, which means that in 8 out of these 18 cases, the MRI findings alone justified a change in the treatment. In 10 out of 18 patients, it was the association of the tumor progression together with the neuro-ophthalmologic findings. But in any case, in all 18 cases of progression, the changes in contrast enhancement characteristic of the optic pathway glioma did not influence the tumor-directed therapy, nor the impact assessment of treatment response, and not even alter the frequency of follow-up imaging. So the decision was not based on the contrast enhancement sequences. Here, another study where, again, the authors compare the accuracy of the MRI with contrast and without contrast in 28 children with progressive optic pathway glioma, this time without NF1, in order to avoid bias in the measures of the tumor, not to be confounded with the UBO. And here the authors reviewed 674 MRIs, which correspond to a median of 24 MRIs for every patient. And here they observed 92 cases, 92 magnetic resonance, where they could document a progression. And they see that out of the 92, the progression was evident in 91 cases of not contrasted MRI. And out of these 92, in 67 cases, there was a change in the clinical management. And in all these cases, in 100%, the decision was taken on the basis of the non-contrast MRI. So they observed a high concordance on the diagnosis of progression between MRIs with and without contrast. And the MRI sequences without contrast showed a very high sensitivity and specificity, 98, 99%, in detecting the tumor progression. The negative aspect here was that the cases with the disseminated disease that were seen in 25% of the children in 7 cases, they were diagnosed in all cases on a contrast enhanced imaging, whereas 1 case was not detected in the MRI without contrast enhancement. And in 4 out of 7 cases, the progression was better visualized on contrast-enhanced imaging. So in conclusion, contrast-enhanced imaging is not necessary to identify tumor progression, as the false negative rate to MRI sequences without contrast enhancement was extremely low, 0.01. However, contrast sequences were superior in identifying patients with disseminated disease, and therefore should be used at initial diagnosis and in patients with disseminated disease. Here, there is another interesting study from a German group in 35 children, again with optic pathway glioma, with and without NF1. And in this case, the authors, they want to see the correspondence between the magnetic resonance and the visual acuity. Since we know that when very often the decision to treat a child with an optic pathway glioma strongly depends on the symptoms rather more than on the radiological aspects, and more in particular depends on the decrease in the visual acuity. So they reviewed 298 brain MRIs, and they assessed some clinical radiological measurement. So we said the visual acuity, the optic nerve maximal width on the magnetic resonance, the intracranial tumor volume measured on the T2 sequences, and a tumor enhancement score. And the results were that the visual acuity is correlated with the maximal optic nerve width in a NF1 patient, whereas in a non-NF1 patient, the visual acuity correlated with the tumor volume. And there was no relevant correlation between visual acuity and the enhancement scores in both groups. And there are also other papers all examining the comparison between magnetic resonance with and without contrast. And they all conclude that the therapeutical decisions are rarely made on the basis of post-contrast imaging, and gadolinium administration could therefore be restricted in the setting of low-grade glioma surveillance. and that contrast enhancement on conventional MRI is not a good predictor of progressive glioma. The enhancement may simply reflect disruption of the blood-brain barrier rather than the neovascularity and angiogenesis that are the hallmark of an aggressive tumor. And indeed, we have to have in mind that in this disease, there could be a peculiar phenomenon, that is the phenomenon of the spontaneous fluctuation of contrast enhancement, as reported by an Italian group that showed that 30% of patients with a stable, non-progressive, non-cerebellar pilocytic astrocytoma show modification of tumor contrast enhancement on MRI follow-up, changes that are in terms of random increase, appearance, or decrease disappearance of the contrast areas in the absence of any treatment. Also, this phenomenon, after disappearing, decreasing, the contrast enhancement foci can also reappear or increase one or more times. So it's called spontaneous fluctuation, and it is also a bias if we want to assess the behavior of a tumor lesion only on the basis of the contrast enhancement sequences. So, when we consider the adoption of the contrast enhancement MRI, we also have to take into account, besides the evidence of the gadolinium deposit in brains and organs with the potential long-term effect, as we said, we also have to take into account the stress for the insertion of an intravenous line, for example, in these children, the prolonged time for the acquisition of the contrast enhancement imaging, the prolonged sedation in young children, and also, least but not last, an additional cost. It has been estimated that the cost for the contrast enhancement sequences in a patient with a sporadic optic-pathway glioma is around $4,000 for a follow-up of an average follow-up of 10 years. Another indication, another case where we could think of not using the contrast enhancement is the case of those tumors that are non-enhancing, the non-enhancing primary brain tumors. Here, a paper about 30 children with different types of brain tumors, all non-enhancing lesions at the diagnosis. The authors observed that during the follow-up, none of these children, except one case, developed pathologic enhancement suggestive or residual or recurrent or progressing tumor. So they conclude that omitting the gadolinium in the follow-up of non-enhancing brain tumor is something that could be feasible. Then another chapter is regards the surveillance protocol for cancer predisposition syndromes. And there are guidelines for every single, for many of these predisposition syndromes that suggest the screening with a brain MRI in those syndromes that predispose to the onset of a brain tumor. And at least for the one that I was in some of those guidelines, such as, for example, in the guidelines for the Gorlin syndrome, for the CMMRD, for the Li-Fraumeni syndromes, the recommendation is to do a first brain MRI with the contrast, and then all the subsequent MRIs during the follow-up without contrast. And then I also, although it's not the subject of this presentation, I wanted to see if also in other fields of the pediatric oncology there is the same interest for this issue. And I was able to find a few papers regarding the neuroblastoma, also in that subgroup of disease. So also in neuroblastoma, there are some papers that start saying that we could consider performing post-treatment abdominal MRI without contrast in selected cases. And they add that contrast can always be added if an indeterminate lesion is encountered at the radiologist's discretion. And also, it seems that also for the definition of the risk factor diagnosis, the assessment could be based on the not enhanced sequencing. So, if we go back to the initial question, brain tumor imaging without gadolinium, is it something feasible or just a fantasy? So, I believe that it is in selected cases, it's probably feasible with a bit of fantasy. Thank you very much.